Okay, first of all, thank you very much for the invitation. It's always a pleasure for me to attend this annual meeting, and I wish I'm there with you physically in Al Medina, but I'm attending the ISHL meeting in Germany. So today, I will present some recent updates on the Burkitts biology, genetics, and also the current understanding of treatment for Burkitts lymphoma. And this is my disclosure. So Burkitt's lymphoma is a disease that we don't usually talk a lot about in the conferences and meetings. So it will be important for us to revise the current understanding of Burkitt's lymphoma. There have been some recent updates in the literature about classification, as well as some updates in the biology and genetics and treatment as well. So I will be talking about some update in the classification from the recent WHO fifth edition, as well as some information about the dark zone family of lymphomas and the molecular subtypes of Burkitt's lymphoma, and then review the current therapeutic options, either in the front line or the relapsed refractory, and some future directions in the treatment of Burkitt's lymphoma. So, according to the recent WHO fifth edition, definition of Burkitt's lymphoma is a mature, aggressive B cell neoplasm that has three features, basically morphologically and immunophenotypically, as well as genetically. Genetically, we all know that the classical genetic abnormality that happens in Burkitt's lymphoma is the MYC translocation with an immunoglobulin gene. And morphologically, typically these cells have a monomorphic morphology with the medium-sized cells and basophilic cytoplasm and multiple small nucleoli, and an immunohistochemistry showing that these cells are germinal center origin with CD10 positivity and a very high proliferative index. There are some essential features and some desirable features based on the WHO. So the essential features, as we discussed, the morphology, the classical morphology we just discussed, in addition to the immunohistochemistry of these cells being CD20 positive, CD10 positive, and BCL2 negative or weak. And the Chi67, the proliferative index, is extremely high, reaching to usually around the 99 or 100% range, with very high MYC expression on the immunohistochemistry of usually more than 80% and or demonstration of MYC breakage based on the FISH analysis. And we do have some desirable but not essential features, such as a starry sky appearance, cohesive growth pattern, and BCL6 positivity and negativity of TDT, positivity of CD38, and absence of the rearrangement by FISH in BCL2 or BCL6 to exclude the high-grade B-cell lymphoma with these rearrangements. In terms of epidemiology, typically Burkitt's lymphoma presents with a high tumor burden at the time of presentation. Usually it's already disseminated and usually present in a very short doubling time because of the high proliferation of the disease, and typically present in extranodal areas, far more common than nodal disease, except in immune deficiency associated Burkitt's lymphoma, where they present with nodal disease more than extranodal. It has a male predominance typically, and in terms of age, it has a bimodal distribution, being common in pediatric at around the age of 10, and also another peak in age of 60s. And we also know that there is a form of Burkitt's lymphoma that's endemic in some areas in Africa, usually associated with the EBV and malaria as well. Typically, this type presents in the facial bones, such as the mandible, maxilla, with also some patients present with abdominal involvement, whereas the sporadic cases typically present in other sites, including GI tract, orbits, and well-entering ring, thyroid, ovary, testis, and breast. The CNS risk, as we know, is very high in Burkitt's lymphoma, either at the time of diagnosis or at the time of relapse. dependent on which study you look at, but at least 30% of cases will have CNS involvement. So this is an important consideration in these patients. Bone marrow involvement or leukemic presentation is also relatively common, happens in roughly 2 out of 10 patients. In terms of subtype, traditionally speaking, it had been divided into 3 basically subtypes of endemic, sporadic, and immunodeficiency or HIV, for example, associated Burkitts lymphoma. But this is mainly, this classification mainly dependent on geography, and it doesn't take into account the biology of the disease. So this is also problematic because many sporadic cases occur in Africa and vice versa. So we do have cases of endemic, what so-called like EBV associated that can happen in developed country and the other way around. So this is not a very helpful classification. So the recommended subtypes by the WHO 5th edition is to use EBV associated and EBV negative rather than the traditional classification. This gives more of a reflection of biology of the disease. Genetically, the primary genetic event is the MYC translocation of the MYC gene in the 8 chromosome with the promoter region of the heavy gene immunoglobulin in 80% of the time, but it could be also with the light chain, either kappa or lambda in chromosomes 22 or 2 respectively, in the remaining 20% of cases. Typically, Burkitts lymphoma actually is associated with simple karyotype. So complex karyotype is quite rare in Burkitts lymphoma, even in the presence of TP53 aberration, which typically present with complex karyotype in other types of like leukemias, for example. But in Burkitts lymphoma, the karyotype is usually simple. The other translocations with MYC with non-IG partners is not something that is associated with Burkitts lymphoma and should basically make us think about different type of diagnosis, like a high-grade B-cell lymphoma or some forms of aggressive diffuse large B-cell lymphoma. This takes us to this recently described the dark zone family or dark zone lymphoma that is presented recently in blood by the group from British Columbia, David Scott and Walid Douaish, where basically they looked at over more than 1,000 samples with the de novo diffuse large B-cell lymphoma, and they evaluated their biopsies to look for their profile by FISH for double hit, as well as immunohistochemistry and the new digital gene expression profile to assign the cell of origin, and also to look at the double hit signature, which was previously described in the literature for patients with double hit by FISH for BCL2 and c-MYC. And there were several key findings emerged from this study that are important to guide this and makes us understand the disease. So the dark zone signature defines a group of aggressive B-cell lymphoma with a common profile that extends beyond the double hit and the diffuse large B-cell lymphoma, and it identifies a subgroup of patients with poor prognosis. Two-thirds of them are negative for double hit by FISH. So although they are not double hit by FISH, but they still have poor prognosis because they are in the dark zone signature. The double hit tumor that lacked the double zone signature had actually favorable outcome despite having double hit by FISH. And what is more relevant for our talk today is that Burkitts lymphoma, actually all of them universally express dark zone signature. So all of the Burkitts lymphoma are actually from this family of dark zone lymphomas. As we can see in this study, the graph in the left upper corner, you can see that basically Burkitts lymphoma, 100% of them have the dark zone, and about 77% of the double hit have the dark zone, while about 15% of the diffuse large B-cell lymphoma, usually in the GCB type. And you can see that the germinal center can be divided into light zone and dark zone, and then the three lymphomas can arise from there. If you look at the freedom from progression, the graph, the Kaplan-Meier curve, you can see that GCB, ABC, in the orange and blue color, they do better than the dark zone lymphoma. So dark zone lymphoma will do much worse compared to the other subtypes, and they have shorter time to treatment days, about 25 days, reflecting the high proliferative disease in these patients. Here also, if you look at the Kaplan-Meier curves, you can see that the lines that are red and green reflect the patients with dark zone, regardless of whether they have double hit by fish or not, and they will have basically worse outcome in terms of freedom from progression as well as overall survival. So altogether, these findings suggest that the dark zone signature identify a dysregulated dark zone phenotype that is shared by different histologically different lymphomas like Burkitts or double hit and DLBCL, and it favors to rename the signature formerly known as double hit signature to dark zone signature. In terms of molecular classification, so also recent study published in the Blood by Thomas et al., where they presented a wide genome sequencing analysis of 230 cases of Burkitts lymphoma, and they aim to discover genomic subgroups dependent on somatic mutations, copy number, alteration, structural variants, and then using consensus clustering algorithms. Similar approach was presented previously, as many of us know, with diffuse large B-cell lymphoma, where diffuse large B-cell lymphoma was divided into 5 molecular subtypes. So a similar approach was conducted in this study for Burkitts lymphoma, and they identified 3 unique genomic subtypes. So the IC Burkitts lymphoma, DGG Burkitts lymphoma, and Q53 Burkitts lymphoma. And each one of these have different clinical features and the molecular genes associated with it. For example, the DGG Burkitts lymphoma is enriched for EBV positive cases, pediatric cases, whereas the Q53 is enriched by EBV negative cases and TB53 mutations. So the primary breakage is the CMYC, but all of these patients will have secondary genetic mutations or hits to lead to the 3 molecular subtypes. Also, just to remind ourselves that there is for prognosis, there is an international prognostic index that is designed for Burkitts lymphoma. Uses similar, more or less similar, variable that is used in the other IPI for diffuse large B-cell lymphoma. So age, LDH, and ECOG, as well as CNS involvement. And with these 4 risk factors, we will have different risk groups. And you can see that the more the risk factors, the poorer the outcomes with these patients. In terms of treatment, the standard of care for Burkitts lymphoma is still undefined, but the current treatment includes aggressive combination chemotherapy with CNS-directed therapy. 3 common approaches exist. One is the intense short-duration combination chemotherapy, examples of which is McGrath protocol or CLGB or the German BALL protocols. Or the other one is the ALL-like therapy, similar to ALL therapy, where you have induction, consolidation, maintenance that lasts for 2 years, or using hyper-CVAD in such cases. And the third approach is infusional chemotherapy with the dose-adjusted EPOCH, which we will discuss. So first of all, the McGrath regimen, the famous regimen that is initially presented in 1984 by McGrath in a small number of patients with the Burkitts lymphoma and lymphoblastic lymphoma, achieving a very good CR of 80%, 82%, and overall survival at 3 years of 60%. Later on, there were many modifications for this Megrat regimen. One of them is the MIAD basically modification, where basically in this study that was published in 2002, they defined patients with low risk as non-bulky, stage 1 or 2, normal LDH, ECOG 1, or 1 or less extranodal sites, and other patients will have high risk. And for high-risk patients, they gave the full Megrat protocol with 2 cycles of Codoxim and 2 cycles of IVAC-R, whereas the low risk, they will only give 3 cycles of Codoxim. And with this, we can see that the 2-year overall survival was quite good, with 70% overall survival and event-free survival of 60%. However, there were high rates of severe mucositis and myelosuppression with this. We can see that you can see the graph from this study that the low risk did better than high risk, which is expected, and you can see the quite good outcome for overall survival and event-free survival over time. Another modification by Lasaki, this was a phase 2 study where basically they decreased the dose of cyclophosphamide to decrease the myelosuppressive effect, and also capping vincristine and reducing the IT cytarabine to reduce neurotoxicity, and also decreasing the IV methotrexate to reduce toxicity while maintaining a good CNS penetration, and also moderately increasing the doxorubicin dose to keep the efficacy of this regimen. With this, 90% CR were achieved and 64% disease-free survival at 29 months. The other regimens, as we mentioned before, they were quite highly effective in pediatric literature. However, their use in adults was associated with increased treatment-related toxicity, especially in patients with HIV positivity. There are many examples of this. So from the European group, whether the basically French group, German group, Spanish group, and also from the US experience, more or less similar outcomes with CR rate between 70 to 80% and around 80% or so 5-year progression-free survival and overall survival. But more importantly, the treatment-related mortality is quite significant, of about 2% to 6%, of dependent on the different protocols. So the treatment-related mortality was a challenge using these protocols. This has led to development of less toxic regimens, like those adjusted EPOCH-R. Levy presented in 2006 a report for Burkitts lymphoma, both HIV positive and negative. This subsequently was published in another phase 2 trial in 2013 in New England Journal of Medicine, reporting excellent outcome, as you can see in the graph, with more than 90% CR and progression-free survival. And there was no treatment-related mortality, which is important. Also, to reduce the toxicity even further, especially with patients with HIV, a short course double rituximab EPOCH-R was developed. So the study that looked at the full dose adjusted EPOCH-R in HIV negative patients, 19 patients, whereas the short course double rituximab was used in 11 patients with HIV positivity. And the difference is that the short course will use double dosing of rituximab per cycle. There was no dose escalation, and there was also response-guided treatment by PET scan after several cycles. And you can see after median follow-up of more than 5 years, both freedom from progression as well as overall survival were quite excellent, whether you use the short course or the full dose of dose-adjusted EPOCH-R. Toxicities were as expected for primary neutropenia, 19% mucositis, and peripheral neuropathy. Another approach is the PET-adapted approach. This is something relatively new compared to the evidence that I presented, because many of the studies initially did not use the risk-adapted approach. So it will be important to think about whether PET-adapted approach can be useful. So this is a study, NCI 9177. This is a phase 2 study, multi-center study, that used dose-adjusted APOCAR in a good number of patients, 113 patients, including HIV-positive patients. This had a really good, basically progression-free survival and overall survival at 3 years, and the majority of cases were high risk. And the response was unrelated whether the patient was older or had an HIV status, so patients would still respond. Low-risk Burkitts lymphoma were treated only with 3 cycles of dose-adjusted APOCAR. There was no CNS prophylaxis. And in this subgroup, although the number were small, but there were no deaths or progression reported. So, of course, the logical question will be which regimen is better, is MIGRATH or dose-adjusted APOCAR? And we do have one randomized trial that looked at this by the Hovon-Sack group. Before we discuss that, we have to remind ourselves that the CNS risk is quite significant in Burkitts lymphoma, as we mentioned, whether at the time of relapse or presentation. The majority of cases, 70%, present in a leptomeningeal disease. Hence, the IT chemotherapy becomes important. But 30% actually have parenchymal disease, where IT usually have less of a role in that case. So dose-adjusted APOCAR, although has the same, roughly the same IT injections as Hyper-CVAD or Codox MIVAC, but it actually lacks systemic CNS penetrating drugs like methotrexate or azacitidine. So it means that patients with parenchymal disease will not probably benefit from this regimen. And this is supported by some retrospective studies that showed that roughly about risk of CNS relapse is actually higher while using dose-adjusted APOCAR as compared to MIGRATH. So almost 2-fold or 3-fold increased risk of having CNS disease after dose-adjusted APOCAR. So this is a concern. Now going back to this randomized study, this is a phase 3 study, multi-center, open-label, that is conducted in several countries, and it included adult patients without CNS involvement but high-risk Burkitts lymphoma, and they were randomized to 2 cycles of MIGRATH versus 6 cycles of dose-adjusted APOCAR, and patients also received for intrathecal and for methotrexate chemotherapy. And the primary endpoint was progression-free survival. Unfortunately, the study was closed prematurely because of slow accrual. However, 89% enrolled in this study, and they were able to present the outcome for these patients. 90% of these patients presented with stage 3, 4, and 11 had HIV positivity. And after a median of 28.5 months, the 2-year progression-free survival was 76% in the MIGRATH protocol, compared to 70% in the dose-adjusted APOCAR, with a p-value that was not significant. So there was no significant difference in progression-free survival. And there were 2 deaths only in the MIGRATH, related to one related to infection, another one to disease progression, and one only death in dose-adjusted APOCAR related to COVID-19. And discontinuation happened in 4 patients due to side effects in the MIGRATH compared to none in dose-adjusted APOCAR. And there were more
Musa, you have 5 minutes to conclude. 5 minutes.
Almost done. Yeah. So 56% of grade 3-5 infections happened in the MIGRATH versus 34% in the dose-adjusted APOCAR. So meaning that dose-adjusted APOCAR was less toxic. It is hard to interpret a study that was closed prematurely and did not complete the sample size, but we can get a rough idea that maybe dose-adjusted APOCAR is less toxic and equal, maybe in some subgroup, but not all patients. Relapsed Burkitts lymphoma is an important topic. It happens in around 20% up to 40% in some studies of Burkitts lymphoma. Unfortunately, there is no standard of care in such patients because we have limited evidence to support our treatment. So this is an unmet need that we need to basically. There are many salvage regimens that can be tried, as we know. These are some of them. but usually followed by a transplant, whether autologous or allogeneic, but usually autologous transplant. How about CAR-T, CD19 directed CAR-T or bispecific? Unfortunately, the studies of CAR-Ts, the pivotal trials usually excludes Burkitts lymphoma, so we don't have enough data from this. So it remains to be experimental. And one of the challenges with CAR-T and Burkitts lymphoma is the rapid pace of Burkitts disease. So while waiting for CAR-T to be conducted, probably patients will progress and will not have time to reinfuse the cells. There's no enough data in bispecifics or antibody drug conjugate, unfortunately. There was one study that presented in ASH last year by a Chinese group, and this included 19 patients using CD19 CAR-T, and it seems that the outcomes were encouraging, but this needs to be basically looked at in the future in other studies to confirm these findings. The CRS rates were 84%, 16% were grade 3-4, and ICANS were 16. 26% of them were 3 to 4, and the best overall response rate was around 50%, and 1 year overall survival was 21%. And we can see that one of the things they looked at was the achievement of remission at 3 months, and this was a poor prognostic factor for patients who do not achieve remission after 3 months from CAR-T. What to look for in the future? There is a drug that is a MYC degrader called the D-ubiquitinase inhibitor, and this is the phase 2. This is a first-in-class drug, multi-center study, recruiting still, no result yet of this study. LongCAR-T, in addition to dose-adjusted APOCAR, this is also a trial that's ongoing. It's a phase 1 for newly diagnosed Burkitts lymphoma. There are other trials now, including Burkitts lymphoma, in their protocol with either CD19 or CD22. So we'll be looking for results from this study. So a suggested algorithm was presented in a recent review articles. So so for low-risk patients, you could try to use dose-adjusted APOCAR without CNS prophylaxis, and then conduct basically interim scan. And if they are in remission, you give 1 more cycle, total of 3 cycles. And if they're in partial remission, you give total of 6 cycles, so 4 more cycles. And if they're high risk, you basically treat them with the MIGRATH protocol. And if they have CNS involvement, of course, you would basically give them more intrathecal chemotherapy. A similar algorithm was also basically presented in the ASCO newsletter by these authors, and they divided patients into fit and unfit. For unfit patients with high risk, you could try dose-adjusted APOCAR with intrathecal methotrexate, and for low risk, dose-adjusted APOCAR for 2 cycles, and then followed by PET scan. And then if they're negative PET scan, give 1 more cycle. If not, then 4 more cycles. And the high-risk fit patients will be treated with the full MIGRATH protocol. And of course, if they have CNS involvement, you would treat them aggressively. So just to conclude, Burkitts lymphoma is an aggressive mature B-cell lymphoma. There have been recent advances in understanding biology and genetics. Biology-driven classification is important rather than geography-driven classification. Multi-agent chemotherapy regimen adapted from pediatric are efficacious, however toxic, especially with the treatment-related mortality, especially in patients with HIV positivity. So short but intensive chemotherapy, like the MIGRATH protocol, has good balance between efficacy and toxicity, but less toxic regimen like diffuse, so like dose-adjusted APOCAR, especially in low-risk disease, are having encouraging results. And the relapse setting, this is a significant portion of patients with less and limited evidence that we really need to have future studies to help us or guide us on what is the best treatment for these patients. And with this, I conclude, and thank you very much.